Welcome back. It's a special pleasure to introduce Anna Newtrick-Whitford, who's a physician scientist and geneticist in the renal division at the Brigham, where she's been on staff since 2022, and she's the director of our genetics clinic and has done lots of lovely work on computational genetics at Children's, and is the anchor of our clinical genetics clinic. Go ahead, Anna.
All right. Thank you so much, Dr. Mount. Good afternoon to everyone. Thanks for the invitation to talk to you today about genetic testing in nephrology. Dr. Mount already introduced me, so I'll go straight through. Our two key learning objectives today are first, to understand the indication, benefits, risks, challenges, and strategies associated with clinical genetic testing in patients with kidney disease. And second, to increase diagnostic awareness of these genetic kidney disorders with a focus in adult nephrology. Of note, given time constraints and the excellent sessions covering these topics separately, I won't focus on these specific genetic kidney diseases in my talk today, and you just had a great overview of pediatric nephrology with Dr. Hildebrandt and Dr. Gomez. All right, so I always like to start this talk with a timeline to illustrate just how rapidly the field of genetics has evolved. It was only 169 years ago that Gregor Mendel proposed the rules of heredity based on his famous pea plant experiments. 80 years later, Oswald Avery identifies DNA as the molecule was responsible for heredity, which previously was thought to be proteins, interestingly. And in 1952, Rosalind Franklin crystallizes the DNA molecule, followed by Watson and Crick's discovery of the double helix structure. In 77, Frederick Sanger develops chain termination DNA sequencing, which we'll refer to as Sanger sequencing. And by 1986, Sanger sequencing had become automated, and this actually powered the Human Genome Project. It began in 1990 and led to the publication of the first draft of the human genome in 2001. In 2005, the first next-generation sequencing system, which we'll talk about later, this particular one was Roche 454, was developed, and that was followed by the widely used Illumina NGS platforms. More recently, novel technologies have emerged, many new things. One of them is the Oxford Nanopore long-range genetic sequencing. That's been a while now, but there's many other ongoing advances, which I won't get into today. However, from a clinical standpoint, it was only in 2001 that the FDA actually approved next-generation sequencing for clinical diagnostics. And when I first joined the Brigham, our options were essentially limited really to the use of research-based genetic testing. However, over the past few years, as you know, the access, cost, and quality of the commercial panels has really changed our practice in nephrology. So how did clinical genetic testing become increasingly accessible? This plot shows the trend in the cost of sequencing one single human genome. Note the y-axis is a log scale, and the cost went from $100 million in 2001, that was the cost of the Human Genome Project, to about $1,000 in recent years. So you can see that while this trend initially followed the famous Moore's Law, which is basically a trend of decreasing costs due to advances in technology, in early 2008, there was a sudden, unexpected drop in the sequencing cost. So this brings us to our first question. What is the reason for this? What happened at that time? In the interest of time in this presentation, I'll let you read through the options on your own, and we'll give about 30 seconds for the replies to come in. All right, very good. So folks, okay, now we're getting some different answers here. All right, so this is a tough question. I'm just testing everyone's short-term memory. But if you recall from the timeline, 2008 was shortly after next-generation sequencing was developed, and across the country, whoops, there we go. Sequencing centers were now switching to this new platform around that time in early 2008. So that was really what caused this drop in cost, and I'll show you why. Regarding the other options, GINA, which we'll talk about later, was enacted in 2008, went fully into effect in 2009. That didn't really change the cost of sequencing. The All of Us program was actually only recently developed in 2015, and the FDA approval for next generation sequencing was actually only in 2011, and the first NGS system was actually Roche, not Illumina, in 2005. So short-term memory, but just to kind of ingrain those findings there, those points. One important point here is that the dollar amount shown in this plot does not include the cost of technology development, nor the interpretation of the raw DNA data, which I can tell you from doing this on my own, it takes an enormous amount of work and time and computing power and human power. So that additional cost is not included here. All right, so what changed exactly and why does this matter to us? I'm going to try and convince you that it does. So with Sanger sequencing, which is what was used for the Human Genome Project, one DNA sequence is replicated several times to differing lengths, then it's ordered by size to determine the sequence of nucleotides. This was revolutionary and still is likely one of the most precise sequencing approaches, but it's slow and it's expensive, and it generates a small amount of data per run. You can see here a chromatogram, which only gives us the sequence for one short stretch of DNA. Next generation sequencing, which I'll call NGS for short from now on, involves massively parallel sequencing, where someone's entire DNA is fragmented, like their entire genome from their cells. That all this DNA is washed through a small flow cell. It's attached. These DNA fragments are then amplified and sequenced in parallel, thus the name. This is an example here of next generation sequencing NGS data, and each line represents similar data to this same data that's generated by Sanger. So you can see there's exponentially more data, which is good because it's exponentially lower cost per DNA sequence. But, okay, so next generation sequencing was a great advance, but now we have this massive amount of genetic data, right? So consequently, we have a huge number of genetic variants are found. I'm sure that all of you are very well aware if you're ordering VUSs on your genetic reports. And many of these variants are individual or rare. So how do we interpret this? In 2015, a landmark paper was published right here, and it established the standards and guidelines for interpretation of genetic variants. These are the so-called ACMG criteria, and they classify variants into one of 5 categories: pathogenic, likely pathogenic, variant of uncertain significance, or VUS, likely benign, and benign. The most important point here to remember is that only pathogenic and likely pathogenic are considered diagnostic or actionable variants, which means they are the ones to be used for clinical decision-making, okay? And these particular disease-causing variants, right, the pathogenic and likely pathogenic, can also be referred to more informally as mutations. But how is this classification determined? I always get people asking that, like, this is a black box. We have no idea how this gets, figured out. And actually, the clinical interpretation of variants is a very complicated process, and it takes into account a lot of information from different sources, which I've summarized here. So when you look at your patient's genetic test report, this is the result of extensive analysis of several data points, including the type of mutation, the frequency of the variant in the general population and disease-specific databases, computational algorithms that predict how damaging that variant is, any experimental evidence that's available and published, inheritance patterns and genetic data within families, detailed clinical phenotype, and the review of the relevant literature. Taken together, this information results in the genetic variant being classified into one of those 5 categories that I showed before. Important points here are that, first, uncertain variants are still, unfortunately, more common than pathogenic variants, which is an ongoing challenge. And second, the variant classification can change over time based on new scientific and clinical information. So the variant can be reclassified over time. I always tell patients your DNA essentially doesn't change, but what we know about it can change. This is a very overwhelming table from those ACMG guidelines, which details each of the specific data points that are aggregated to define a variance classification. You can see, as I mentioned, all these different sources of input and the direction, so benign or pathogenic, and strength, strong, supporting, very strong, of each of these different criteria. Then, depending on the criteria checked off for the variant that we're looking into, we will fall into one of these 5 categories, right? So we take, we aggregate those different criteria and we then fall into these 5 different classifications. This is the process that determines the official classification right here that shows up in the genetic test report, as I've shown here in this example. So this is where this all comes from. All right, so let's go to our first clinical case. As a note, all the cases I present here are adapted from patients I've seen in clinic. I have modified them for privacy and didactic reasons. So this is a 26-year-old pregnant woman, no past medical history, presenting with preeclampsia and severe lower extremity edema. Creatinine of 0.8, eGFR is fine. She has 3+ protein on the UA, a UPCR that's almost 3.5. And when we take her family history, her dad has proteinuria and had ESKD at 50, which was attributed to hypertension and diabetes. After delivery, renal biopsy is performed, and you can see the findings right here, light microscopy and electron microscopy. And the question is clinical genetic testing indicated? And if so, what is the recommended initial strategy? All right. Any brave respondents? All right, good. So people know their genes here. We're getting now different answers. So this patient, if we summarize, has early onset familial proteinuric kidney disease with likely nephrotic syndrome and a biopsy showing, right, FSGS and widespread podocyte foot process effacement. Okay, so if we think about this, this is what we would recommend, okay, currently would be doing a targeted panel of testing of at least 50 genes. And this would, so, there's different panels which we can do. I'll get into that, but we would cast a wider net than a smaller net. I know, several people pointed out here NPHS1, NPHS2, TRPC6. Great, those are the top candidates, but we know that there are other genes that can be involved. So currently we'd go a little bit wider. So back to the case. What is this, right? What does this patient have? So her presentation is very suggestive of a genetic podocytopathy, also called genetic FSGS or SRNS. These are caused by mutations in genes that encode proteins responsible for maintaining the integrity of the slit diaphragm, podocyte structure, and the glomerular filtration barrier. These mutations cause, the abnormal proteins that result lead to glomerular injury, podocyte foot process effacement, proteinuria, and ultimately glomerulosclerosis. Now, the histologic spectrum really depends on the patient's age, the mutation, and the progression of disease, but can range from diffuse mesangial sclerosis, mostly seen in pediatric populations, to the equivalent of minimal change disease, histologically, FSGS, and even collapsing glomerulopathy. These non-specific lesions represent patterns of podocyte injury, and so that's why currently we have been using more and more the term podocytopathies. And importantly, this most often does not respond to steroids or immunosuppression. All right. Research done by Dr. Hildebrand, as you saw in his talk earlier today, and others have shown that dozens of genes are involved in genetic nephrotic syndrome, mostly localizing to the podocyte. And it's, as I mentioned, it's important to differentiate this, especially when we're thinking about management of the patient. You can see here the podocyte foot process effacement. So for this patient, interesting, let me go back. We're going to find a mutation in this gene right here in the podocyte, which is TRPC6. And what we know is that single heterozygous mutations in this gene TRPC6 cause autosomal dominant FSGS, usually through a gain of function mechanism. The protein becomes overactive. And I'm going to pause for a second because I forgot to plug in my computer. I apologize. There we go. All right. So this is what we found, and this is the cause for her familial FSGS. Now, you'll see here again pop up those VUSs in the report, which often is a nightmare. In this case, just an example of the approach here. So she has a variant in FN1. Could this be fibrillary? First of all, we didn't see that, on the biopsy. But secondly, if we look at the details here, the reason this is not pathogenic. She has a very low prediction score, hasn't been described in the literature. So we're going to ignore that. Similarly, with this other VUS, this is responsible for severe early onset multi-organ abnormalities. If you do have a real mutation in this gene, she does not have that clinical presentation. So we're also going to disregard this. But at the end of the day, remember, from a medical and even legal standpoint, the positive variants are the ones that are clinically actionable. All right. So TRPC6, very interesting. It encodes the transient receptor potential cation channel, subfamily C. Member 6. When this channel becomes overactive, this causes high intracellular calcium in podocytes, and this ends up disrupting the actin cytoskeleton and causes the detachment of the podocyte foot process from the GBM. So that leads to proteinuria and ultimately sclerosis. And very interesting, research shows that inhibiting TRPC6 reduced renal fibrosis in animal models. And I'm super excited to share that earlier this year, the results of the phase 2 trial with apecotrep, which is a small molecule TRPC6 inhibitor, shows decreased proteinuria in FSGS patients. So very exciting when genetics informs treatment. Going back to the case question, let's review the indications for clinical genetic testing in nephrology. So we suspect monogenic or single gene cause of CKD when there's strong family history of CKD, when the etiology of CKD is not clear after we thoroughly investigate, when genetic information is really crucial to guide medical decisions, when patients have an unexpected CKD course, when kidney disease develops at a young age, and this includes young adults, and when certain extrarenal manifestations are encountered. The young one we just discussed actually had 4 of these indications highlighted here. So great, we want to do genetic testing, but what tests do we order? Let's look quickly over the different clinically available types of genetic testing. I know this gets very confusing, so I've tried to illustrate and summarize here. So looking here, let's imagine we're seeing part of someone's DNA, a fraction of which, right, as an example here. And there's 3 genes, gene A, gene B, gene C. Each gene is composed of exons, which are coding regions that give directions for building the amino acid sequence of a protein, right, the exons, and then the introns, which are non-coding regions of a gene. Targeted variant analysis is the most simple analysis. It assesses known familial variants. It's straightforward. We're only looking at one particular variant. Sometimes companies will do it for free. We don't have any incidental findings. Disadvantage, obviously, this is very limited, right? So it's what it's called, targeted. Sanger sequencing is, as I mentioned, it's very precise, but it's expensive. It just gives us a little bit of data there. Usually we use it for single gene analysis that's not well captured by next generation sequencing. Targeted gene panel is what is most currently and widely used and available. It's obtained through next generation sequencing, but it looks at the exons of a list of genes. Okay, so we are looking at coding regions and just a particular subset of genes. This is the go-to test if you're dealing with a clinical presentation that could be caused by a mutation in any of a number of different genes. You know, this is, as we saw, the case for genetic FSGS, right? There's a long list of genes there. And they're easier to order. They're usually lower cost. The copay is usually relatively low and, you know, a couple $100 or sometimes waived. The quality of the sequencing is good. So, you know, this is what we often use in testing. But the downside is that the analysis is limited to that list of genes. If there's an additional gene you want to look at afterwards that maybe wasn't included, can't do that. Can't go back and pull in other genes. All right, then we have, whole exome sequencing. This is obviously a much bigger test where you look at the exons of all 20,000 genes essentially across the genome. Again, just the coding regions. And this is more useful in syndromic, complex, or atypical cases. It's more difficult to get, oftentimes need prior auth. So it's a little bit tougher, but we are using it more and more, especially when the targeted panel is negative. And then finally, whole genome sequencing is really mainly used on a research basis. I think some clinical genetic services are now using more genome sequencing, but we in nephrology at this point don't really use that. It's when we look across the entire DNA. And obviously this is great. It gives us more information also about structural variants, but it's a ton of data and a lot to go over. All right. So let's look at one of this. Oh, I'm so sorry. Next question, audience response question 3. All right, so we're testing a patient. What's the chance that we'll get a positive genetic test in general among adult and pediatric CKD patients, all comers, with some caveats? All right, great. So we're in the right ballpark. Very good. So based on different studies, and of course, this depends on the study, but in general, ballpark, about 10% in adults and about 30% in children. So let me go over one of these studies that was, again, a landmark paper that came out in 2019 from Columbia. And this showed at the time what unexpectedly high yield of genetic diagnosis in CKD patients, right? They did research exome sequencing in over 3,000 patients. They found a genetic cause in almost 10% of cases. But it's important to note, I always point this out, this cohort was enriched for severe kidney disease. Okay, so 65% had ESKD. A lot of them were second opinions, complicated cases. So just to be aware of that bias. As expected, family history of CKD was associated with significantly higher yield of genetic diagnosis. And the most common genetic findings were mutations in the genes PKD1, PKD2, you saw PKD talk earlier today, and type 4 collagen genes, which are associated with Alport as well as UMON. Another very remarkable aspect of the study was that genetic diagnoses were made across the whole spectrum of clinical presentations: cystic, glomerular, hypertensive, and unknown etiology. When we break down the diagnostic yield by clinical category, you can see that the congenital cystic disease had the highest percentage of genetic diagnosis, about 1 in 4 patients. But a genetic cause was also found in about 7% of patients with glomerular disease and a whopping 17% of those with CKD of unknown origin. All right, so question number 4, let's go to our second case. 42-year-old female referred for microalbuminuria during an uncomplicated pregnancy. This persisted postpartum. Her lab showed creatinine of 1.1, UACR 150. Her last UAs over the last 3 years had 2+ blood, some RBCs. Extensive serologic workup is negative. And then when we take a family history, never forget, father's a heavy smoker, had end-stage kidney disease at 45. His ultrasound had a few kidney cysts. His biopsy had thin basement membranes and FSGS, and her sister has blood in the urine, which was attributed to these 2 left cysts that she has. So what diagnosis is this we're most likely looking at, and what are the genes that are involved? Okay, I think my questions are good because I'm getting lots of different answers. All right, so this is a tough question. There's a lot of red herrings here, but the main clue here is the thin basement membrane. Okay, so this is most consistent with autosomal dominant Alport syndrome, and specifically with mutations in the genes collagen 43, collagen 44, and I will explain why. Alport syndrome. This is an inherited primary basement membrane disorder. And it's not just the GBM, but it's also the basement membrane. It affects the basement membrane in the eye and the cochlea. And it's caused by pathogenic variants in the genes that encode the type 4 collagen alpha 3, alpha 4, and alpha 5 chains. A very important concept here is that there's these three different collagen 4 alpha proteins. They intertwine together to form a heterotrimer. Okay, this cord-like structure, which then connect to each other to then help form the structure of the glomerular basement membrane. And all three chains, so all these three different genes and their protein products, are required in the mature kidney. And even if one of them is abnormal or missing, the entire structure is going to have problems. If we look at the position of these genes, we'll know that collagen 4A3 and collagen 4A4 are located next to each other on chromosome 2, whereas collagen 4A5 is located on the X chromosome. So this contributes to the genetic heterogeneity of this condition, which can be X-linked, it can be autosomal recessive, or it can be autosomal dominant. And this gets very confusing, especially when patients go to Dr. Google and ask about Alport syndrome. Alport syndrome is also clinically very heterogeneous. There's findings that range from hematuria all the way to ESKD, hearing loss, and ocular disease. And over the last few years, what we've discovered is that Alport syndrome is much more common than we previously thought, as you saw in that study that I just showed you. And it's often a misdiagnosis in many different renal clinical presentations. So Alport syndrome is a multi-system disorder. From a renal standpoint, there's glomerular hematuria, sometimes with episodes of gross hematuria, proteinuria, and ESKD. An important update in recent years is that we now know that kidney cysts are a relatively common finding in Alport syndrome. Okay, this sometimes can confuse folks with like atypical PKD, and the cysts can be couple or several and bilateral, although much less than in classical polycystic kidney disease. And an important difference is that advanced CKD, due to Alport syndrome, the cysts are often seen in atrophic kidneys, very different, again, from the nephromegaly and massive cyst burden that you see with advanced ADPKD. Sensory neural hearing loss may be present, as well as ocular abnormalities such as anterior lenticonus, plaque retinopathy, and corneal erosions. Less commonly seen are aortic aneurysms and rarely leiomyomatosis in X-linked Alport. Now let's jump to the renal pathology, and here we have a normal GBM for reference. As you know, Alport syndrome was initially described with the characteristic basket weave GBM on the kidney EM. Individuals with this typical finding were found to have complete absence or abnormality in one of the three Alport genes. So basically here you have one of those three is completely dysfunctional. So either two mutations in collagen 4A3 or 4, or one mutation in collagen 4A5 in a male. Now, what happened is that about 25 years ago, the research community noted that individuals that had thin GBM often had a mutated Alport gene, but in this case, it was only one of the two copies, with the other copy being normal. For example, one mutation in collagen 4A3 or collagen 4A4, or one mutation in collagen 4A5 in a female. And so these cases, while initially this was thought just to be a carrier or just a benign thin basement membrane, what we know is that this can actually lead to potentially to advanced CKD. Finally, we also now know that any type of Alport syndrome can progress to FSGS, as you see here, and FSGS is often present in Alport patients that have advanced CKD or end-stage renal disease. So taken together, these important discoveries have really changed the way that we approach Alport syndrome now as a spectrum or a heterogeneous disease with several different subtypes of varying severity. To try and make this as easy to understand as possible, which I know is tough, and also for your future reference, I created this table based off the 2018 position paper of the Alport Syndrome Classification Working Group. The points I want to highlight here specifically are that the diagnosis of X-linked Alport in females has now substituted the prior denomination of carrier status. We know that due to lionization, right, the X chromosome inactivation, females can have very variable clinical disease, up to 25% with end-stage kidney disease. Second point, heterozygous variants in collagen 4A3 or 4, as I showed, can lead to thin basement membrane, but this is not always benign. Similarly, can lead to ESKD in about 20% of patients. So now, in general, we do refer to these patients as autosomal dominant Alport syndrome, although I was just in a meeting yesterday discussing whether or not this is the right term to use. So more to come in the next year or so on terminology. Third point, given the relatively high presence of the collagen 4 alpha variants in the population, patients may carry mutations in more than one of these genes, and we call that digenic disease, and that can also that can often lead to disease that's more severe than having just a single mutation. All right, finally, let's talk about management. Angiotensin blockade is the most important intervention in Alport syndrome. Studies using ACE inhibitors shows that this substantially reduces proteinuria, can dramatically slow cirrhosis and CKD progression. Timing is crucial. So if you remember one thing from this talk, let me go all the way down. I think it got there. Is this table? Which is the timing of start of RAS inhibition, depending on the Alport classification and their microalbuminuria. So whenever a patient has dominant Alport or X-linked in a female, whenever their UACR is greater than 30 milligrams per gram, please start RAS inhibition. This can really change the course of disease. If you already have the patient on an ACE or an ARB and their UPCR is still high, and here it's debatable, but around, if it's higher than 1, then you can, or lower, I prefer lower. But anyways, you should add other strategies to suppress proteinuria. Here, sometimes we use MRAs. SGLT2 currently is not in Alport syndrome guidelines. It is actively being studied, but I feel like the whole community now is very comfortable with using this, especially in cases where patients have other risk factors. Renal transplantation is the preferred option for ESKD. Remember to very carefully evaluate living-related donors if they also don't have subclinical Alport. And there's a very low 3% risk of anti-GBM GN in the allograft for specific patients that have complete absence of one of the 3 proteins. Remember to check eyes and ears, okay, for any complications. There's no formal guidelines to screen aorta yet, but you should consider it in males with X-linked Alport. And finally, importantly, patients that have Alport syndrome and have FSGS without other apparent cause, you usually, after thorough investigation, that can be attributed to the Alport syndrome, and then that's a situation you can avoid immunosuppression. All right. Question number 5. So this patient that we just talked about showed, their panel showed a heterozygous variant in collagen 4A4. So they did have autosomal dominant Alport syndrome. It also shows a heterozygous likely pathogenic variant in NPHS2. Biallelic mutations in NPHS2 cause autosomal recessive nephrotic syndrome. How do we interpret this NPHS2 variant from a clinical standpoint? All right, any thoughts here? Any brave responses? All right, so this is a tough question, but you can see here, very good. Okay, carrier status, great job, brave responder. So let's discuss the difference here of these two things, because there's a lot of confusion about what between especially VUS and carrier status. So a variant of uncertain significance is a variant that is unable to be classified into one of the other 4 categories, right, that we talked about before, the pathogenic and benign categories. So what this means is that our current evidence cannot determine, based on those ACMG guidelines, whether the variant is pathogenic or benign, and it's stuck in this limbo. In principle, as I mentioned, VUS should not be used for clinical decision making, but in some cases, because we have more data than the testing laboratory, expert review and additional data can help reclassify this variant into disease-causing or benign. If the VUS is in a gene that's consistent with a patient's disease, then family testing can actually help reclassify the disease. For example, if there's strong correlation between the disease and the VUS in different family members. For example, here a note, the PKD2 is a gene for PKD. I have a patient who had genetic testing. They had a VUS 5 years later, a VUS and PKD2. 5 years later, we repeat the test with a different lab. Now we have much more information. This variant is now considered pathogenic. All right, how about a carrier? So a carrier is an individual who carries a pathogenic variant in a heterozygous state for an autosomal recessive disorder. Okay, remember, for autosomal recessive diseases, only one abnormal gene copy does not cause disease in that individual. By definition, recessive disease is caused by 2 abnormal gene copies. So the patient carries the variant, but that should not affect them. But it can be carried, right, along, passed along to their offspring. If a child inherits another mutation in the same gene from the other parent, then they should develop the recessive disease. And this is a lot of counseling that we do for our patients that are found to have variants in a carrier status. For a carrier patient, again, the variant should not be considered disease-causing unless there's new scientific evidence that there are clinical consequences of variant in a heterozygous state. And we've seen that, as I just showed you for the Alport syndrome, right? Eventually, we found out that heterozygous variants also caused issues. And another example is PKHD1. It's responsible for autosomal recessive PKD. Initially, the carriers were just called carriers. Now we know that they can also have a kidney and liver phenotype that's much mild. All right. Question number 6. We have a patient, 55-year-old male, hypertension, hyperlipidemia, gout, and slowly progressive CKD4. His ultrasound shows slightly small kidneys. He has a couple of medullary cysts, increased echogenicity. His UA is completely bland. He gets a biopsy, which shows 70% IFTA, nothing else. Serologies are fine. Now, family history he has a sister with CKD in her 40s, a maternal aunt with ESKD in her 60s, a maternal cousin with kidney issues in his 50s, and the patient's parents died relatively young in their 50s. He has a 30-year-old daughter. She's seeing her father's kidney function decline. She wants to donate a kidney. So for this patient, what is the most likely clinical diagnosis? And I've drawn out the pedigree here to help us think. So I'm going to move a little bit faster because I still have some material to cover. Great. All right. We have the first responder there who's getting most of these right. Yes, this is a case of typical ADTKD. This is very often a misdiagnosis. So ADTKD, autosomal dominant tubulointerstitial kidney disease, is a disease with obviously autosomal dominant inheritance, as the name implies, and it causes slowly progressive CKD. Impaired renal function typically appears in teenage years, but it can be much later, and ESKD onset is usually in later adulthood. There's bland urine sediment, which is one of the big clues here, with no or minimal proteinuria. Occasionally there are cysts, sometimes medullary, and the biopsy just shows diffuse IFTA. It can be associated with hyperuricemia, and there's not many other non-renal manifestations aside from gout. It's the third most common monogenic kidney disease, about 5%, so, after ADPKD and Alport. This is an example here of the renal pathology, diffuse tubulointerstitial disease. Oftentimes we don't even do the path if this is a high, if it's high risk biopsy, or if we're this history of very suggestive, because again, it's just going to show IFTA. This table summarizes the different genes that cause ADTKD. So UMOD, MUC1, renin, and HNF1 beta. There are many shared characteristics, and you'll see here a lot of, especially like I mentioned, the hyperuricemia, the gout, the occasional cyst, but there are also some specific clinical findings that help point towards specific diagnoses. For example, with renin, it can be anemia, hypotension. UMOD, renin, and HNF1 beta are usually included in broad kidney gene panels, but MUC1 testing is extremely challenging, and it's only available at select labs, including the Broad, where this was initially developed. I did want to briefly review HNF1 beta related disease. It's very particular when it comes to its constellation of findings. The HNF1 beta B gene encodes a transcription factor that is involved in kidney development. It can cause a wide array of kidney abnormalities, cysts, hypoplasia, dysplasia, single kidney, and it can mimic other kidney disorders because of that. It's an autosomal dominant disease with significant clinical variability. Remember that this is a transcription factor, and even within the same family, it can be quite different. There are many possible extrarenal findings, including neuropsychiatric disorders, early onset diabetes, exocrine pancreas dysfunction, genital tract abnormalities, abnormal LFTs, and very importantly for nephrologists, hypomagnesemia and hyperuricemia. Always remember to check your uric acid and mag levels on these patients have cystic or structural kidney abnormalities. Last case, this patient, one more follow-up for that prior case. So this patient has a high quality, extensive very broad gene panel, it's negative, nothing. So the question here is, all of the below points are potential benefits of genetic testing for kidney disease, except for what? And I just want to make a comment here that I'm just excluding instances of targeted familial variant testing. Give a couple more seconds here. I know there's lots of options here. So I'll just start chatting a little bit. So I've seen this many times. We end diagnostic odysseys by getting a diagnosis. We can refer to clinical trials. We can guide management, even if that's limited to some genes. We can inform prognosis. We can screen, like I just showed you for HNF1 beta. We do a lot of extrarenal screening. We can do family counseling. Ruling out genetic cause of kidney disease, I see most people respond to that, and that's exactly the point I want to make here, which is a negative genetic test report does not rule out a genetic cause of disease. I want to make a point that this is excluding targeted familial variant testing, where there we are seeing if the patient has or not a known disease-causing variant, right? But in general, if someone's coming to your clinic and we're suspecting we have a high suspicion of genetic CKD, and the test report comes back negative, that doesn't mean they don't have genetic CKD. So why is this? For number one, a gene might not be included in a specific panel. For example, we can do cystic or FSGS panel that doesn't have collagen, right? The Alport genes, or for example, might miss HNF1 beta. Sometimes the mutation, the gene, the mode of inheritance might not have yet been discovered. And here you probably saw in our PKD talk earlier, cases of IFT 140. Or more commonly, the variant might not be captured by next generation sequencing. This is the case for non-coding variants, structural variants, and very repetitive DNA regions, which is where MUC1 falls. And so this particular patient actually had MUC1 testing sent separately and showed the classical cytosine insertion, so has MUC1, ADTKD, and this was great because the patient's daughter is tested for the variant, does not have it, does not have any kidney issues, and is able to safely donate a kidney to her father. Remember, she might, if she did have this disease, she might have been asymptomatic at her younger age. All right, last case, will be real quick. 50-year-old patient referred by ophthalmology. We're not really sure why Ophtho sent us this patient. Ross is kind of vague polyuria, polydipsia, intermittent pain in legs, hands. He's on B12 and gabapentins, recurring abdominal pain, nausea, diarrhea, cold intolerance. They told him he had anxiety. Mom died in her 40s of a heart attack. The daughter has protein in her urine during pregnancy. A little bit of CKD, a little bit of proteinuria, a little bit of cysts. This is his physical exam. What is this disease? All right. So what you see in the physical exam are actually these elevated red papules. They're angiokeratomas. So this is a classical finding of Fabry disease. All right. So Fabry disease is the most prevalent lysosomal storage disorder. It's caused by a deficiency in alpha-Gal A enzyme. This is responsible for cleaving GB3. If it doesn't cleave GB3 accumulates in multiple cells and tissues, and then you have this multi-organ involvement. Obviously, this is caused by mutations in the gene that encodes this enzyme. The gene is GLA, and GLA is on the X chromosome. So this is an X-linked disease. Again, a recurring theme here, phenotypic variation in women due to X chromosome inactivation. And the clinical course is correlated with how depleted the alpha-Gal A activity is. With, if it's none or minimal, it causes classic Fabry. But if you have some residual function, because the mutation isn't that bad, it can cause atypical types, presentations of Fabry. Treatment is enzyme replacement therapy. It's an infusion every 2 weeks, but there's also the option of pharmacological chaperone, which stabilizes the mutant alpha-Gal A, increases enzyme activity, but it can only be used for specific genetic variants. So genetic testing is important again here. Kidney disease, we do RAS inhibition, transplantation if needed. Survival is a little bit lower because of the other extrarenal comorbidities. This is usually the clinical presentation. You'll see, cardiac disease, CNS, renal, GI, corneal opacities, angiokeratomas, and that pain in the hands and feet, which is very typical. It's the first symptoms called acroparesthesia. The reason the ophthalmology sent this patient to us is because they were found corneal whorling on their exam. From a clinical standpoint, renal-wise, there's accumulation of that GB3 in tubules, podocytes, causing dysfunction, as well as potential cysts. Last but not least, very briefly, this patient did have a variant in GLA, but also was found to have a pathogenic variant in RET. Okay, this shows up on our report. What do we do with this information? RET is associated here, it's listed in the report with MEN2A. So do you refer this patient to cancer genetics endocrinology? Do we call the patient and say everything's fine? Do we contact the company and tell them that they put a wrong gene on the panel, the patient doesn't have cancer? Do we call the patient and say, this is irrelevant, it's incidental, or do we contact their family and do cascade testing? So here, again, as I've gone over a little bit, this is a true variant, and I'll show you why it's important. The reason it's listed there in our kidney panel is because it can actually cause kidney disease. It's involved in organ development. So it can cause CACUT, congenital anomalies of kidney and urinary tract, but it also can cause MEN, right? Multiple endocrine neoplasia. This particular variant that the patient had is very well established in families with MEN2A, and almost all of them have medullary thyroid cancer. Often this is multicentric. They might also have pheochromocytoma. So in this particular patient, we immediately referred them to cancer genetics, endocrinology, and surgical oncology. This patient actually was found to have high PTH, high calcitonin, and had a thyroidectomy, which showed medullary thyroid cancer. And then obviously family members are now being screened. All right, so this is a summary of important things when we talk about pre-test and post-test genetic counseling. Again, there can be positive results with the likely pathogenic variants. GINA protects health information for employers and for health insurance, does not cover life insurance, disability, or long-term care. Always important to bring that up for patients. Negative results doesn't rule out genetic disease. Uncertain results we see a lot of with the VUSs, and then as I just showed you, there can be incidental results. Consent is always good, I think, mainly for an educational purpose for patients, but a lot of institutions also require written, even signed informed consent before genetic testing because of all these uncertain outcomes. All right, so I'm just leaving you here with a table of a summary of indications for genetic testing for your future reference, as well as summary of the talk with some important take-home points for you to review later. And some recommended reading and references. So thank you so much and good luck.